And then at this point, I'd like to introduce our moderator, Wendy Rogers, AIA CEO of LPA Inc. And she will introduce our panelists.
Great. All right. Well, thank you, everyone. And thank you, Jeff, for going through a lot of the housekeeping details and all the information. It's probably really good if we just ask everyone to hit their mute button for the majority of this presentation. And then as we get into Q&A and discussion, we can certainly have people unmute at that point. So anyway, good evening, and thank you all for joining us for tonight's session. We have a really robust group of folks here and a really great topic this evening. So tonight, we hope to give you all insight into the changing world of healthcare and what is needed to provide care in today's post-pandemic state and share how CHALK views and is addressing the landscape. If you are on this call tonight, you are surely interested and passionate about creating innovative environments that promote healing and wellness. And you are also surely curious about how healthcare will come to you and to our communities differently in the future. So thank the committee for organizing this event and Jeff for inviting me to moderate. And even though I am in this position, I am actually very excited myself about what I'm going to learn this evening from our exceptional and distinguished group of panelists that are going to share the impact CHALK is having on their campus, in their community, and on the global stage. So I think the only thing before I get started is to share that we are recording this, or at least I think that was the decision. There goes the red light, I think, and it'll be available on the AIAOC website. Each of our panelists are going to share their perspective and some slides in a PowerPoint for the first part of our program, as Jeff mentioned. And so throughout their presentations, if you want to be putting your questions into the chat, by all means, please do so. And then for the second half, we'll be reviewing each of those questions and asking the panelists to be able to weigh in and share their point of view. So we really hope that the stories shared tonight will be meaningful as we all work to better serve our OC ecosystem and beyond. So let's get started. So first, I'd like to introduce Dr. Anthony Chang, the Chief Intelligence and Innovation Officer at CHALK, who will be sharing the role of CHALK on the global stage. And Dr. Chang, I know you referenced COVID is breaking through the innovation ceiling and how intertwined intelligence and innovation is to build better tools and how we collaborate. We're really glad to have you share both a national and international perspective on integrating AI and why this is important to pediatric healthcare. Really excited to hear you. Thanks and welcome, Dr. Chang.
Thank you, Wendy, very much. And I want to thank also my good friend and colleague, Tiffany Gear, for thinking of inviting me. So when I first got the invitation, I thought AIA was clearly, or obviously artificial intelligence something, and I realized it was actually about architecture. So I have a confession to make, which is I'm actually, my first passion in life, actually, when I was 13, 14, I wanted to be an architect. So in a way, this is an interesting homecoming for me. Now, do I share my slides? Or do you have the slides? There you go. Okay, I was told there was a master deck. So yes, I wanted to be an architect, and then to make a long story short, I went to a heart seminar series at the NIH and changed my mind. So, but I still am very much into design of things, as Tiffany knows. And I think when we talk about the future of healthcare, we really need to pay attention to what's happening in the real world, or the virtual world, I should say. So in this case, Mark Zuckerberg, as you know, talked about the metaverse as something that we need to do to be in the experience rather than watching or doing something. So I think that's how I like to see us approach healthcare for the future. Next. So the exciting thing about something like metaverse, again, this is in the context of emerging technologies. Okay, yeah. Thank you. Speaking of metaverse, that was on the guess in the metaverse. Okay, so it's a convergence of technologies, and I think we all have now heard about extended reality, either virtual or augmented reality, but that combined with artificial intelligence and blockchain in the future is really going to, I think, significantly change how we interact with one another. Obviously, nothing will take place of an in-person meeting face-to-face with a handshake and just sort of warm human feelings for all of us. But I think this is the best technologies can offer. Next. So I think Next slide, please. So the previous slide, please. So I think thank you. So what the AI part of Metaverse is going to be is providing, enabling the architecture of Metaverse, which consists of avatars, so representations of us. So that's going to be a lot of computer vision. It's going to enable language for communication, and also lastly, make use of data. So we haven't talked about that part too much, but all the data that's going to be accumulated and part of Metaverse will be very, very important for very highly efficient communication and interaction. Next. Oh, thank you.
Sorry.
Okay, I'll go quickly. So both from AI perspective and I think architectural perspective, this is a perfect blend because you want to focus on patient experience. And on the left, there is a picture of an environment that we're considering with Philips, which is ambient intelligence. So that's sort of the ideal convergence, isn't it, between AI and the environment, which is what all of you are focused on in terms of the architecture of things. Next. I think another thing that's very applicable for AI and healthcare, advance please, is embedding intelligence in everything throughout the whole experience. So AI essentially becomes embedded into everything that we do so that the Internet of Things becomes Internet of Everything, which is the connection of things that are becoming more and more intelligent. So as we speak, MIT engineers have already embedded a primitive artificial intelligence neural net into a microprocessor. So in this decade, we're going to see a tremendous surge of capability of wearable devices and sensors, which are a very, very important part of healthcare. Next. And lastly, I think AI in healthcare, advance please, yes, is going to be, we're going to be virtualizing as many elements of healthcare as possible. So that's exciting because we can actually create what we call digital twins or virtual twins, essentially digital copies of our health experience and our records so that we can actually perhaps consider different interventions to improve our health. And I'm part of a big effort that's launched late last year called healthcellcal.ai, which is leveraging AI for health from infancy on. So that's the exciting thing is we're essentially doing the Framingham Heart Study, 3.0 by following patients virtually for the next 40, 50 years to see what health interventions really make a big difference. Next. So virtualizing everything in healthcare. And advance, please. So I was inspired by the Event Horizon Telescope project, which enabled us to see the black hole. And this is from 13 telescopes around the world, creating a coalition of telescopes. And I see that in the future of healthcare is all of our health systems and AI and healthcare centers need to become one cohesive network so that we can learn from each other. So I'm really inspired by that. And I'm the privileged convener of such a group. Next. So I think in the future, this is the Pediatric Alliance of AI and Medicine Centers. We now have about 20 from around the world. So I think it's a very exciting time that in the middle of trying to really leverage AI to its fullest to improve patient outcomes, that we have basically 20 centers and hopefully more as we go on to really have a singular focus of improving children's health. Next, and leveraging artificial intelligence. So I just want to thank our MI3 Institute, which focuses on artificial intelligence as well as innovation in pediatrics at Children's Hospital Orange County, and also my very smart and good friends and colleagues from Stanford School of Medicine. So thank you very much.
Terrific. Thank you. And thank you for your patience through all of that. I'm not seeing any questions in the chat immediately, so I think without any further ado, I would like to introduce our second speaker, Dr. Michael Weiss, Vice President and for Population Health at CHOC, who will be sharing the role of CHOC in the community, dedicated to helping children and their families lead the healthiest lives possible. He will share lessons learned from the implementation of telehealth and how it is impacting care delivery. So welcome, Dr. Weiss. Thank you for joining us.
Thank you, Wendy. Just a sound check. Everybody can hear me okay?
Perfect.
Perfect. Great. I'm always humbled to follow Dr. Chang because I still balance a checkbook and make copies of everything. And he's talking about avatars and twins and things like that. But he keeps me honest, so that's good. Thank you all for having us. I'm Mike Weiss. I'm a general pediatrician by trade. I practiced in the community for 22 years, and I've had the good fortune to be at CHOC now for about 8 years. And part of our population health division at CHOC is the oversight of our telehealth program. So what I want to do is give you a little bit of granularity about what's happened over the last 2 years with telehealth. And I think then maybe pose some kickoff thoughts for some of our Q&A as we go forward. So if we go to the next slide, please. I will be completely frank with you. Prior to COVID, our goal for the year was to do 400 telehealth visits. That's for the year, just so I can clarify. COVID hit and we had the stay-at-home order. And all of a sudden, we saw this marked reduction in people seeking healthcare. And one would say, well, that's great. Fewer people getting sick, fewer people seeking healthcare. But in pediatrics, it's kind of a different world. A lot of healthcare in pediatrics is preventative healthcare. It's well child visits, it's immunizations, it's safety, it's prevention. And so we really had to gear up very, very quickly. And we saw this 70% reduction, but we geared up across the board in all of our primary care, our specialty care, all the different offices across the board. And we focused primarily on those highest risk kids, those kids that have medical devices, that have chronic conditions, and again, the very young that require that anticipatory guidance. So if we go to the next slide, I'm going to share some numbers with you. Remember, our goal for the year was 400 visits. At the peak of COVID, we were doing in the neighborhood of 700 visits per day. Needless to say, I met my goals and objectives for the year, which was wonderful. That's a joke, but by the way, we have done somewhere in the neighborhood of 160,000 telehealth visits now since the onset of COVID. And you can see this graph. This is fiscal year 22, so this is most recent. This doesn't even really represent most of the peaks, but you can see where the peaks are, particularly January. That was our last COVID surge. So this all really correlates with the availability and access to healthcare. Again, orange is specialty care, blue is primary care. Next slide, please. Just to give you an idea, didn't transmit very well, but just to give you an idea, on the bottom, these are the types of specialty visits that we are seeing. So a lot of gastroenterology, very, very importantly, a lot of mental health visits. And this is something I think we should explore later in the program today. Neurology visits, pulmonary, obviously non-surgical specialties, medical specialties where being able to do an effective telehealth visit was highly beneficial. If we go to the next slide, please. One would ask then, well, how were the patients with this? And I have a number of slides that I could do on this, but the bottom line is that our telehealth patient satisfaction equaled or surpassed our in-person visit satisfaction. And this has been consistent and sustained even after the COVID surges that we've seen. So not a surprise to you all, because you're all consumers. People love it, and they're going to love it in the future. So we have to be ready to deliver it. If we go to the next slide. So what will dictate the future of telehealth? And again, these are really more provocative bullet points to get us kicked off for the discussion. But the public health emergency will expire soon. I believe it's either April or May. And when that expires, so too will some of the laxity around telehealth coverage and telehealth payment. We know in the Medi-Cal population, so Medicaid in California, that the state has expanded on those relaxed rules, and that will remain in place for the Medicaid population. But we have a lot of concern about the commercial population. We have a lot of concern that the commercial payers are going to look at their run rates in terms of what they've been spending, and they're going to get everybody out of the pool, so to speak. So we have to be very, very cautious about that. There are a lot of regulations around the sending and receiving location. If I'm a licensed physician in California, which I am, can I provide telehealth services to someone in Arizona or in Hawaii or in Dubai for that matter? The payment parity that has been underway where telehealth visits are being paid equal to in-person visits, another thing we have our eye on. I talked about Medicaid. In California, we have what we call the delegated model. So our local medical groups like the Monarchs of the world that you've heard of, or St. Joe's Heritage or Memorial Care, they really are the ones that dictate what they will and won't pay for, because they serve as the mediator between the health plan and the medical delivery of these services. And then we really do still need to talk about the disparities in care. We all walk around with our devices and we have easy access to the internet, and that is not necessarily the case. I can tell you, we did telehealth visits with kids at the donut shop or at Starbucks because it was the only place that families could get broadband access. And then lastly, and this is a very, very serious issue, is we have to document quality. Telehealth is great as far as access, but how do we objectively demonstrate that we're delivering equal or superior quality to an inpatient visit? And what are the use cases for telehealth? Obviously, if somebody has appendicitis, we're not going to do that via telehealth. If somebody has an ear infection, without devices that Dr. Chang was speaking to, where we can actually look in an ear and make that diagnosis, what can we actually do? So all of that, you know, if I'm in your shoes as architects, you're thinking about what that workplace, that medical facility of the future looks like. And that's all going to be based upon volumes. And those volumes will be dictated by these variables that I just described. So thank you.
Well, I can see that we have a handful of questions around some of the things that you covered directly around the telehealth no longer being covered by Medicare, Medicaid. Is that accurate? Will they still be accessible or offered if insurance companies are no longer willing to cover?
Yeah, I think I covered a little bit of that.
Yeah.
I think on the Medicare, Medicaid side, because CMS, the Center for Medicare and Medicaid Services, oversees that, I do believe that we are in a good position that a lot of the telehealth services will continue to be covered in those populations. I have a lot of concern around the commercial insurance companies. And I think, you know, I'll call to arms on this call. What will drive that is consumerism. If people demand it and the insurance companies are not covering it, there will be a mismatch there. So call to arms is when you, as an employer or with your employees, this is something to really explore when that open enrollment comes around and you're making your decisions about who your insurer will be. I know that's an unsolicited comment, but it is what will drive it. It's consumerism that will drive it.
Yeah, and that was kind of the second question was, do you see telehealth change with that kind of retailizing? I think that's the word they were trying to say, of medicine and more devices that will be in the home. So. Yeah,
I think we're already seeing that. There are a number, you know, if you go online and Google, I want a telehealth visit, you can be seen 24/7, 365. By whom, I can't guarantee in terms of the quality of care. And we do know that if you look at the literature on pediatric patients, there is a higher prescribing rate for telehealth than there is in person. In adult medicine, not that big of a deal, but in pediatrics, it's a much bigger deal if we're overusing antibiotics. I'll defer, you know, Dr. Chang has a lot of experience with the devices. We can share a little bit later some of our remote patient monitoring that we're doing as well.
Terrific. All right. Well, thank you. Okay, and then I think to round this out, I would like to introduce John Henderson, the Vice President and Chief Information Officer at CHOC. We'll be sharing the role of CHOC technology on campus. And as I sit here in a hybrid work environment that was actually full today, it's been really nice here, but surely the last few years have been completely transformational. Your deep experience in this critical field of information technology has everyone wanting to know how the needs of the hospital have been impacted by COVID and the broader changing landscape of technology. So welcome, John. Really interested to hear what you're going to share tonight.
Thank you. Thank you. Happy to be here. I'm John Henderson, CIO for CHOC. And if you can go to the next slide, please. I'll walk through kind of three different elements. I'll give you a little bit of insights as it relates to what's happening from a remote workforce, hybrid workforce, share a little bit about what's happening at CHOC, talk a bit about what does the future of space planning, facility expansion look like in this new world that COVID's kind of brought to everyone's doorstep, and even talk some about what digital patient experience looks like going forward and the impacts of the evolving landscape of technology and how rapidly things are changing. And then hopefully take a few questions. Next slide. So if you think about remote workforce and what has transpired, kind of the latest surveys really reveal that flexibility. In this particular survey with Gartner, 75% of folks want to have flexibility in the way in which they work. And then another 39% of the workforce would really be at risk of leaving your organization if you decided to bring everyone back into the office full time. So that flexibility in work is really critical, and it's what our workforce is really demanding with the onset of COVID. And now that everyone can see the capabilities and how productive you can be while working remote, but really the amount of flexibility not only gives to the employees working, but also to the organization. And it creates a scenario where you have to think very differently about the workforce and what you want to do from not only a facility perspective, how you provide care for the patients, as Dr. Weiss previously talked about, from a telehealth perspective, and even from the types of experiences you want to offer your patients, patient families. Next slide. So this is a little bit of a profile of what CHOC looks like from a workforce perspective. So right now we're 33% of our workforce is in some sort of remote category. So we break things down into three: either you're full-time remote, 8% of our workforce is full-time remote. Hybrid, which is really kind of the 50-50, half the time you're in the office, half the time you're remote. That's another 7% of our workforce. And then the telecommuting really represents a wide variety of really less than 50% of your time is spent in the office, while the majority of the time is spent working remotely. And we give a wide variety of what that represents. That could be you come in the office one day a week, you might come in 3 or 4 times a month. There's a wide variety, and it really aligns with the previous insights from the previous slide around flexibility is top priority for the workforce. And not only for CHOC, but I think you're seeing that really across the country. Next slide. So I wanted to give a little insight. As CHOC went through this process, we looked at 3 different divisions and looking at space. So everyone's remote. We sent about 1,500 of our workforce completely remote. And as we started to look at what does that mean from a space perspective, we had 3 divisions that looked at consolidating into one shared space. And as we looked at that, we kind of forecasted what do we think we're going to need in physical space to house 3 different divisions: IT, revenue cycle operations, financial operations. And we wound up having a target that we could reduce our space footprint by about 71%. We actually wound up achieving a reduction of 74% of space reduction with this move. And what it really required you to do is really be really thoughtful and meticulous about who's going to be on site full time. And for those who are really telecommuting, how many physical spaces are you going to need at any point in time so that you don't run out of space? And so the other thing you wanted to make sure is you have the ability to book the space, reserve the space, So you don't get into a scenario where you have so many people showing up, but not necessarily enough cubicles or offices to accommodate. So that reservation technology is really important in the process. Next slide. So as you think about how do you optimize space for the future, some of the key considerations really has to be understanding that your remote workforce, what their preferences are. We've done a number of surveys to make sure we understand what that looks like, because it can be an evolving landscape. So redesigning and thinking about conference rooms, that's going to be a really critical thing from a facility expansion and design perspective. On the following slide, I'll show a couple examples of what that really looks like. But if you think about, you're going to have folks working on site. They may come to a conference room. You think about the folks who are working remote, they join the same meeting. In today's world, that's a bit of a fragmented experience. And the future of that really is, how do you create a more immersive, engaging experience? Because you're going to continue to have this hybrid on-site, off-site remote experience. And so to be effective, you're going to have to change the layout of conference rooms. You're going to have to look at different technologies to make sure you can really present that immersive experience. Digital boards across the organization will become more ubiquitous. You'll think about real-time location services will become standard. The ability to track patient equipment, to track any type of equipment across any of your campuses is going to be critical. Dr. Chang talked about AR and VR technologies. Those types of experiences, while they're in their, I say they're fairly early stages today, they will be standard service offerings. If you're going to differentiate, and if you're going to really take advantage of these capabilities to enhance the experience of your patients, you're going to have to offer these capabilities. Some of the expected outcomes talk about reducing space, but really the level of information and insights that you're going to garner from the technologies is going to be critical for figuring out what's the best way to deliver meaningful and enhanced patient experiences, whether it's understanding your flow and how many people are coming in and out of your facility, whether it's understanding what their experience is like when they visited in real time and being able to really respond to those needs and make adjustments. Those are going to be really important outcomes for the future of optimizing space for the benefit of the patient experience. Next slide. So I wanted to just give a quick snapshot of what a future state conference room model would really look like. On the left side, you have more of that immersive experience where you have the conference locations, the conference rooms, conference tables really directly in front. Folks who are remote, they're looking directly at the folks who would be in that conference room. On the right-hand side, this is a layout that can really support both experiences. Whether you have everyone fully on site in the conference room, you can still present content and have a meaningful experience. But also, if you have folks who are remote and some folks are in the conference room, you still get that sort of immersive experience where you can be actively engaged with the folks who are remote and also see and share content throughout. So that's really the future state that I think you have to spend a tremendous amount of time with when you're designing conference rooms from a facility expansion perspective. It's going to make all the difference, because the hybrid workforce is not going away. And if you're going to create an experience that is engaging, then that's where you have to go. Last, I want to talk a little bit about digital experience. Oh, no, it's okay. You can advance one more. So if you think about, if I do have to come in, where do I go next? Most hospitals and health systems, it's kind of hard to navigate. So think of having a QR code that you can just take a snapshot with your phone, and it can help you navigate step by step to your appointment where you need to go. No more wandering around the parking lot, no more wandering around the campus trying to find your location. Easy way to help you get to where you need to go. Next slide. And then, from a patient experience, everything is digital. Mobile is going to be key. While you'll have web experiences that need to match the mobile experience, most of the audience is really going to be focused on mobile. And so you want to create something simple, elegant, and easy for patient families to leverage. As you think about it from a pediatrics perspective, it's not only the patient, but you're also talking about the patient's mom or dad or guardian that really has to interact with these capabilities. So whether it's getting the right alerts, whether it's assisted navigation, as I mentioned before, even language translation, having those capabilities are going to be critical in order to deliver that differentiated and experience that's really meaningful. Next slide. And also, I think one of the key things is making it personal. So we have a wealth of information about our patients, and we want to be able to present that in a way that's meaningful, so it shows that we actually understand, and not only do we know about your experience coming to CHOC, but we can serve you up information that is most meaningful to you. So if you've come to CHOC for several different appointments, we know that we want to serve you up information. If you come in for asthma before, we want to be able to serve you information to help you manage that and provide the best pediatric content around how to help manage your condition. We want to make it fun, make it gamified, having different types of digital rewards. So as you make progress on your journey, you get rewarded through this mobile experience to make it fun and exciting for you. Next slide. And then finally, I'll just mention being able to show the overarching journey of your experience. One of the big things that is important in healthcare is a patient family, they want to understand what it's going to cost. And so being able to provide that level of insight and information through this mobile experience, so you have an understanding of what this visit is going to cost you before you actually come in for that visit. And having easy, flexible payments is also something that creates the type of experience that most folks are used to. So if you're used to Apple Pay, Google Pay, we want to offer the same type of experience, simple and easy for patients' families to leverage. But at the end, it's really about creating that simple, elegant experience and being able to offer that to your patient families. If you're not on this journey today, we're headed down this path. The consumer and the patients, they're going to demand that you get there. So this will become more of the standard as opposed to being an exception.
Thank you very much. I can see that the questions have started to come in, and I was going to layer on one of the ones that had actually come in while you were talking, Dr. Weiss, and Dr. Cheng, you were responding to it. You know, how will AI medical benefits and processes become available to all members of society? And, you know, you talked a little bit about health inequities, but I think we just saw kind of a follow-up there with, you know, what services are we offering to patients without smartphones? So what kind of dependence do we have on this, and what are our alternatives?
Yeah, I think a lot of inequities in healthcare system, as Michael and I always talk about, is actually unintentional, but it stems from access issues, and we just kind of perpetuate that inequity and exaggerate that health inequity. So I think, you know, as Alan Turing, who you probably have all now seen in the movie The Imitation Game, said, you know, maybe we can't always rely on humans to neutralize some of the issues. We need a machine to look at some things. And I see in the future how artificial intelligence done in the right way can actually pick up on these inequities and help to neutralize it as best as we can. Maybe humans alone are not enough to really neutralize those health inequities. But I love that question, because if we don't do artificial intelligence right in healthcare, we can actually perpetuate those inequities, and it'll be very hard to discover.
And Anthony, I'll just add to that a little bit. I think that what we have learned in medicine over the last couple of decades is that despite the fact that we're doctors and we think that our pen is the key to healthcare, it's really about what we call social determinants of health. And you may or may not have heard that term, but the reality is that steady food resources, steady shelter, safety, all of these things play as great, if not greater, a role in healthcare. And part of that is also the access to a lot of these devices and these ways to get to healthcare that we've been describing. So I think that, you hear of communities now where, and I think there are some in Orange County, where there is just universal broadband available. The community pays for it. These are the types of things that are going to reduce some of these inequities that exist today.
Thank you. One of the questions that we just had come in, do you see the digitization of health requiring more physical space, less physical space, or about the same? I think all of us as designers and architects were pretty astounded by those percentages that you shared.
Right. It's going to require less space. You think about support services, not in the clinical setting. So you're not going to reduce the space in the clinical setting, but I think where you see that reduction in the kind of the rethinking of what support services facilities look like, you have a real opportunity to shrink that space and make it more flexible and usable, where you see more collaboration spaces, huddle spaces, hoteling, and really the use of large digital boards throughout those facilities in a way in which you don't really see today, unless you're sitting in Silicon Valley and large technology vendors. They've been doing this for quite a while, but I think you'll start to see outside of that those types of arrangements and designs coming forward.
I think some of the discussion is less about more or less space, but perhaps the really intelligent way to use the space. And Michael and I were working on a clinic redesign as an example, and our innovation team was brought in to discuss with our clinic design team, perhaps how to position the clinic exam table, or how to redesign the layout of the room. And from this telehealth experience, I realized that I was a privileged guest to our patients and families by being on Zoom to be in their usually family area. And what a great sanctuary that was for this patient and family to have the comfort of the home. And I was thinking, when we bring them into the hospital and the clinic, we kind of perhaps underappreciate the sanctuary feel of the family and the patient in the home. So I was thinking that instead of trying to figure out where to put the exam table, perhaps we don't need the exam table because we didn't have it during the pandemic, and that we basically maybe modify the design of the couch and that we have in the clinic room, and then perhaps most of the time we actually don't need an exam table, because it is kind of an obvious piece of furniture in the clinic room that perhaps we don't absolutely need. So in terms of innovation and architectural design, I think one of the first things I learned about innovation is you kind of have to unlearn what is conventional and traditional to think of something novel. And perhaps we don't need the exam table. That's just a small example of how to make better use of the space.
Certainly, and I was thinking along those lines, because we've come across a lot of that in our educational settings as well. Dr. Weiss, maybe you could comment a little bit about how chalk is crossing into the school systems. School nurses, quiet spaces, being able to reach more students potentially more equitably that way.
Yeah, I think that's a really, really proud moment for us as chalk. One of the facts that I always like to throw out is that in any given community, for instance, in Orange County, chalk has the opportunity to really be involved with only about 5 to 7% of the population. And one would say that's great, because that means that those are, the sickest kids, the injured kids, the kids with cancer, that type of thing. But what it really does is creates an opportunity whereby 93 to 95% of the families are out there, but we don't have any contact with them. And so chalk about 5 years ago made a very conscious effort in its strategic planning to go to where the children are. And where are the children? They're at school. And so we made this very conscious effort to outreach to the Orange County Department of Education and a number of the local school districts, and actually formalized it with memoranda of understanding, focusing really on 3 or 4 different areas. We first of all asked the school nurses, what is it that you want? And what they wanted, not surprisingly, was communication. They felt isolated, and they felt like they weren't hearing from our subspecialists. And so we worked diligently with John Henderson and his team to create a HIPAA and FERPA. FERPA is the educational form of HIPAA, compliant access for the nurses in the school setting to be able to look into our EMR for patients that they had direct care relationships with, to help them to coordinate care. And anyone on the call who has a child that has an IEP, an individualized education plan, or a 504 plan where they get accommodations of any kind, that communication is extremely important. And to my knowledge, and I can be corrected, we are one of the, if not the only hospital system that has allowed that access to school nurses. Certainly in California, I know that. I just gave a talk at the School Nurse Association. The second part of it was around care coordination. So how do we help families navigate the system? We know healthcare can be challenging to navigate, and it's very important to us as CHALK that we try to ease that availability. We try to ease that way to get through the system. So we have a nurse care coordinator available to the schools to be able to reach out and help to facilitate care. And then lastly, I'd like to say we were really smart, but I think we were also a little bit lucky. Prior to COVID, we embarked upon the idea of well spaces in schools. And I'll shamelessly plug, if any of your firms are interested in philanthropy, this is a great opportunity to help provide an opportunity for kids in the local school system to have a place to be able to go and chill. And these are spaces that are separate from the office. They're decorated in what we call a biophilic design. You guys, I'm sure, know that term. We have a couple of professional companies that are doing that design for us. And we have 8 of these open. We just received a $2 million philanthropic gift to open 17 more of them. And our plan right now is to have 30 or 40 of them across Orange County. And it's just in time, to be honest with you. What we are seeing with kids as they go back to school, and I'm sure you're all experiencing it in your own lives, is just a tragedy in terms of the mental health issues that we're facing. So really working with the schools to address all of those issues.
Yeah, I think we probably will come back to some of those mental health issues. I'm curious, just kind of picking up on that. John, maybe you could kind of share a little bit about how CHALK is managing the devices and apps with the explosion of digital solutions that are out there, and maybe a little bit more information around remote patient monitoring.
Sure. You know, from an application perspective, and you know, there's just tons of solutions out there. So some of the things we've done, not only from the workforce perspective, there's been a number of offerings that have come through our associate health clinic to really support the mental health aspect of it, and just making sure that our workforce knows those resources are available. When it comes to, you know, there's just so many solutions out there focused on whether it's patient engagement, patient outreach. It seems everyone has a new app that they want to sell you to help improve your patient experience. You know, what I've seen in what's really effective is not that there's a one size fits all. You really have to understand what experience you're trying to deliver, what capabilities you need to offer to your patient population, and then really focus on delivering that. You know, I'll say the large EMR vendors, they come with patient portals. And this isn't to disparage those, they serve a purpose, but they're not going to create the type of engaging, personalized experience that you need to provide for your patients. And so you have to really be thoughtful around how you create that solution. And sometimes it means you'll buy some solution to get you started, but you're going to have to build upon it and expand it to really create the experience that's unique to what you're trying to offer. And I know Dr. Chang is probably going to have some thoughts on the remote monitoring. You know, we do a little bit at CHALK, but I think that's really the future. One of the biggest things with being able to do it effectively, particularly when it comes to the wearables for pediatrics, really is the number of devices that are available in pediatrics, and then to have the integration so that data can flow back into whether it's the EMR, in a way in which the provider can really consume it, and it's easy for them to access the information. And it's not just a ton of data that they have to sift through. It has to be presented in a meaningful way, so they don't have to do all of that manipulation. But I'll let Dr. Chang jump in. I know he has some thoughts on this one.
You're spot on, John. It's not just giving all of our patients, including the youngest ones, the capability of wearable devices and sensors. And our population is getting older too, so we need sensors as well. But it's what do you do with all the data that comes streaming in? And I think very, very important part of wearable technology and sensor technology is coupling it with AI, so that so that the data is filtered correctly, so that the most important information, not all of the information, the most important information can be delivered to our providers in a timely manner. And this requires pretty sophisticated AI technology to be embedded into these devices. But we'll see this by the end of the decade. So this is a very exciting time as we all become more and more connected, but in a meaningful way. It's sort of the development of a nervous system for the entire planet that we're undergoing right now. So it's very, very exciting time, and really, really great for patient care in the future.
So one question that might be related to that is, with more wearable devices, do you see patient stays at hospitals shortening with early discharge?
Yeah, go ahead, Michael.
No, I'll jump in first and you can jump in, Anthony. Yeah, I think so, but two very important variables on that. One is just having a wearable device that's transmitting information is part of the battle, but you also have to operationalize it, because there has to be somebody on the other end or artificial intelligence interpreting that data. So to John's point, it's about the connectivity for sure. The second piece, quite frankly, is the return on investment, the monetization of it, the ability to be able to get payers to see the value in funding these types of devices so that it's a sustainable approach. Very honestly, right now, many of our wearables we use under experimental protocols. We do pilots with companies that are trying to prove the concept. So it's very challenging on the insurance side to get a lot of this stuff covered, which in turn reduces the sustainability option.
I was just going to add that I'm a pediatric cardiologist, so I often take care of some of the sickest babies that will ever leave the hospital. It's not just getting them home earlier, but it's also ways of monitoring them strategically so that you don't risk a readmission to the hospital, especially in a bad situation. So it's more than just leaving the hospital earlier, it's preventing them from coming back to the hospital with an emergency.
So one of the questions that we had here were what drivers, and we're kind of going back to this, what drivers will determine the amount of telehealth utilized going forward? There were a couple more questions around these notions of telehealth.
Wendy, I'm sorry, you broke up a little bit. You said what drivers?
What drivers will determine the amount of telehealth using going forward? And I'm going to switch my headset, so while you respond.
No, that's fine. I think we alluded to some of those, but a lot of it is really demonstrating quality, which in turn will inform insurers as to the ability to continue or advance their coverage for this. I mean, I hate to make it sound like this, but the reality is, outside of Medicare, Medicaid, what determines the volumes going forward is whether the insurance companies will pay for it. It sounds terrible, but it is exactly what will dictate this.
Well, even though I'm a pediatric cardiologist, I see adult patients too. I notice, and Mike, maybe you see it in your practice too, I see the telehealth and the need to be on site. Let's just take the need to be on site to see a patient and family. It's kind of a U-shaped curve. The younger the patients are, the more desire for me to be seeing these patients in person, just like my oldest patient population. It's the millennials and the 30, 40-year-olds that rather just stay home with a visit. So I think there's a tremendous age difference in how these families and patients look at telehealth and whether or not it's an asset or an inadequate substitution, I think remains to be seen.
Do you think that's one of the biggest challenges that's faced between pediatric care versus adult care?
Yeah, there's a huge difference in pediatric care when it comes to telehealth. I mean, well child visits in the first couple of years of life, you must have your hands on that child. The common tumors that are seen in children are usually emanating from the kidney. I can't see that on a telehealth visit. I can't feel that on a telehealth visit. There are devices, but looking at the eyes to make sure that there's no problems with the back of the eye, the retina, or the cornea, or the lens. There are so many aspects of the physical exam in a newborn or an early life child that have to involve physical contact. And remember, what Anthony was talking about is very real. The 20 to 50-year-old in general is the healthiest population that we have. And they're going to use telehealth for things like, I have a sore throat, I want an antibiotic, or my ear hurts, I want an antibiotic, or I have a cough, I need, a cough medicine. And in adults, you can get away with that. But in pediatrics, we don't use a lot of medicine for regular kids, right? Most of the stuff kids get, they get better and it goes away. And we want to maintain that. We want to maintain the integrity of the evidence-based medicine. And to do that in a telehealth environment where sometimes less than evidence-based provision of care is being delivered, you have to be very, very careful. And Wendy, Dr. Feaster, Bill Feaster, who is one of our colleagues, looks like he has a question or a comment.
Yeah, I just wanted to interject telemental health here, because whereas physical medicine may require, an actual presence, or at least every once in a while, you're going to have to see the patient, put your stethoscope in your hands on them. But telemental health is something that the telemedicine may actually provide an advantage for the patient, creates an environment that may not be so intimidating, certainly will improve their access. And mental health is such a incredibly understaffed area right now. There's so much more need than what we could ever provide. Telemedicine for telemental health is going to be an incredible boom to telemental health.
And also AI-enabled telehealth visits for mental health will be another big bubble, I think, because the need is so great right now. Especially, we haven't even seen, I think, the tsunami of mental health issues, because we're still in kind of a shock state with the pandemic. But as we recover and hopefully leave the pandemic behind, I think the mental health issues will really start to surface in a big way. And we simply don't have enough human caretaker, especially on the pediatric side, for mental health issues.
Yeah. And Wendy, I'm going to expand on Dr. Feaster's comment as well. And I wrote something in the chat, but care coordination in pediatrics, especially for those highest risk children, is often a team-based approach. So we may have a doctor, a nurse, a social worker, a nutritionist, a respiratory therapist, a pharmacist, all part of that care team. And the telehealth approach has actually been just absolutely perfect for that type of visit, because it's not necessarily focused on a physical exam, but more focused on creating a single care plan that the family can work from, and assuring that the right hand and the left hand are talking to each other, which is something that we don't do well in healthcare today.
Yeah, and we're seeing a lot of bravo in terms of, removing that stigma of walking into a psychiatric hospital, et cetera. Telehealth has been amazing for our employees who have been really interested in being able to reach out during this time. It's been transformative in that sense.
Wendy, there's
Yeah.
even the notion that perhaps an avatar is superior to a human mental health caretaker, because the patients feel like they're a lot less judgmental. So at least the avatars haven't developed facial expressions yet. As humans sometimes humans just can't help themselves to have a facial expression that, the patients can pick up very easily. So it'll be an interesting decade in terms of how the mental health support is going to develop in various parts of the world. So.
Yeah, certainly. And we had another question. How do you see VR affecting healthcare facility design? Will it further reduce person visits, or, will the elderly be comfortable using it?
Since I brought up metaverse, I guess everyone is looking at me to answer the question. I think it's going to be a fascinating evolution in terms of healthcare design. I think the four of us that you see here, from Chat 5 to counting Tiffany as well, we're all for making the children's hospital experience a lot less like the traditional hospital setting and much more like a home, or much more of an adventure, and especially for our pediatric patients. And that means that it could be the same philosophy in the design for adult hospitals too. I mean, we've all been in a hospital, most of us have been in a hospital, and you much rather have it as less artificial and mechanical as possible. And that absolutely adds to the healing process, your mental state. We often underestimate that. So I see a slow but relatively significant change in how we look at hospital design, and that's where all of you come in. And I think we're already working with a few companies that see this mental health aspect of the hospital experience as a very, very important part that we've not been perhaps emphasizing enough in the past. I think that's going to be a big change.
And we are using VR now, but it's more around pain and helping kids to get through procedures. So we're using it in the perioperative area, as well as with blood draws and things like that. And we've had some good successes with that.
I feel like this may be one of the finale question, but I'm not quite sure. But what one piece of information would you want architects and designers to know when they are designing for pediatric healthcare? Who wants to take that one on?
What's the one thing? Yeah, I would say it's something we've all talked about. Really just completely reimagining what the facility needs to look like, not only in the clinical exam room and clinical setting, but also in the support services. What it looks like and what we've traditionally done, I think you're going to see a 180 in approach to that. I think if you don't look at it that way, then I think the facilities won't really provide the outcomes that you're looking for, not only in function, but also in experience.
I think from my standpoint, I'll look at it very clinically and not so operationally. I think that pediatric care is different in that we, as I mentioned a moment ago, are very team approach. And so when you look at development of spaces, I do believe that we have to accommodate for team-based care, whether that's virtual or in person, but that accommodation for providers of different disciplines to contribute to a care plan and really work with a family is, I think, extremely important in design.
Wendy, I don't know where you got a hold of my comment about the pandemic breaking the innovation ceiling. I don't remember where I said it, but I think it really did. I mean, I know John and Michael and Bill already know this, but about a year and a half before the pandemic hit, as the Chief Innovation Officer at CHOC, I was given the question, what would I change about our workplace? And I said, get rid of everyone's offices and make everyone part of the hospital, and blur the boundary between administrative offices and the hospital. And at the time it was pretty radical, and I was even had a group discussions with people about how's that ever possible and why, and I said, well, the exchanges, you can use all that extra space, wellness centers, parent support areas, and make a use of that extra space. And now, 2.5 years after the pandemic, we're all pretty comfortable working from home. I think we miss the human touches for sure, but I think it just gives you the opportunity, as and a famous author said, the pandemic gives us a new portal to a new world. And I think the new world hopefully will be much more sensitive to our human-to-human interactions. And I think if I had one takeaway is, let's get the kids and the patients and families involved in the design, because they probably, especially the ones with chronic diseases, I think they know the hospital much better than the doctors and the architects will ever hope to understand.
Yeah, I was going to say COVID has absolutely accelerated the pace of change, I think, for all of us. But I'm really appreciative of the way, even as you're talking about these really big concepts in AI, everything's about human-centric and making things personal. And so perhaps as I'm checking for kind of questions coming in, one of the last ones here was, how will intelligent buildings and technology change the way healthcare is delivered? I don't know if it's a mashup of those two ideas or something very different.
Well, one of the things I say is AI hopefully will rehumanize medicine. I feel like, even coming down to the doctor or the nurse with a computer in the room is really dehumanizing. And sometimes the eye contact isn't even there anymore. So I feel like hopefully with ambient intelligence and natural language processing, all of these AI tools will bring back the human aspect of and humane aspect of medicine and its delivery. I think that's so vital and so important.
Medicine is a very interesting profession when you talk about technology, because you really have to weigh the science versus the art. I'm old enough that I go back to having a beeper and using a payphone when I used to get beeped. Anybody who called after hours, I went to the hospital to see them, and I knew them and they knew me. And I'm not trying to say that I'm a dinosaur, but I will say there are positives to that period of healthcare. People knew their doctor. They were able to communicate with their doctor. And today we've just gotten so big and so complex and so technologic that I'm just editorializing here, and Anthony will probably disconnect me, but I think we have to weigh the personal nature of that relationship with your doctor with the technology and the access and the ease of connecting. There's a sweet spot there, and I don't think you have to lose either, but I think it's incumbent upon us to create that sweet spot.
And Michael, you'll probably be surprised because I often get asked, what is the best piece of technology in healthcare? And they often expect, answers like one of the artificial intelligence tools, but I actually say it's the stethoscope. It's our privilege to be close to a patient, and that's accepted by society. And I really do mean that. I think that the best part about technology that's coming up in the next decade or two, it's going to bring back the human and the humanity of medicine in a big way. And I expect that. And I think it's a great opportunity for our architects and design thinking colleagues here to really think about the human aspects of medicine and not compromise. Sometimes it's very easy to compromise to a solution that is technology enabled, but doesn't have the human aspects of medicine. And there are ways you can really perhaps think more and think harder about how to do it without really having to have it go back to status quo. And I think the pandemic is a great opportunity to get away from the status quo. If you go around the hospital, even look at monitors. Why are monitors necessarily a box in a room, and why can't it just be behind the wall, so to speak, and we just look at it when we need to? I mean, if you really have a fresh perspective, as I think all of you do, as designers, you can really just almost forget about the old world of hospitals and clinics and think about how you would design it from a totally blank canvas.
Yeah. Well, I was going to say, I think Dr. Chang, you are not the first doctor that I have met who said they were originally going to go along the path of becoming an architect until someone came into some class and showed them a model of a brain or a nervous system or something that they became even more fascinated with. So I do think there's something similar about the process. And you actually use the words design thinking and the fact that both of us always are looking at what's most critical for the patient. I mean, the doctors and people are important, right? But it's we're all in the design of what we're doing, trying to really understand it through the lens of the patient experience, truly. So, and Tiffany, you even mentioned it would be really great to be able to keep this conversation going and explore more of what we can do together between CHOC and the AIA to create innovative solutions. And I think that's a lovely note probably to end the evening on, actually. Most of the questions that are coming in now, aside from some of the ones about, wow, this could help us actually deliver medical care in space one day and some other real great ideas. I think it's just been really terrific to have you each share your point of view and your perspective about the future of healthcare, and just really pleased to have been a part of this conversation tonight. And thank you all very much for giving of your time to our design community so that we can continue to do a great job elevating the experience for patients. Terrific. Thanks so much.
On behalf of our team, thank you for giving our hospital and a few stakeholders the opportunity to share our thoughts with you. It's very unusual for us to get to speak to a group like this, and it took, I think, forethought and creativity that you have to get us to speak to you. So thank you very much for that.
Thank you very much. Bye.
Thank you.
Thank you.
Thank you, guys. Good night. That was super. Really
Thanks so
appreciate it.
much.
Thanks, Tiffany.
Great
Thank
job,
you.
Wendy.
Thanks, Jeff.
Thank you. It was an excellent program.
All right. Bye, everyone.
Have a great night, you guys.